All right. Well, hi everyone. My name is Masha. So I did my practicum at BC Children's Hospital Center for Mindfulness under PHSA, the Public Health Service Authority for BC. And this presentation is based on my culminating report. It's a reflexive examination of what it means to evaluate a mindfulness app inside a settler colonial health institution and what that process taught me about public health practice in general. So just to begin, I wanted to kind of outline this quote as well. Settler research positionality is not a disclosure made once at the top of a paper. It is a practice held continuously throughout the work. So throughout my practicum, I was able to work with Indigenous Health, which is a department at PHSA. I'll explain a bit later, but I thought it would be important to share my positionality. So I am a white first-generation immigrant from Ukraine to Canada. I live and study on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I do really believe and value the Center for Mindfulness's work. And at the same time, this practicum led me to develop sort of a critical literacy to ask harder questions about what it means to institutionalize and measure relational and Indigenous informed ways of being inside a structure that has historically harmed the communities it now seeks to serve. So the little introduction here for what is Breather and what is the Center for Mindfulness. So Breather is a free, barrier-free mobile app, and it focuses on guided meditations. So there's no account needed, and it was co-developed by BC Children's Kelty Mental Health Resource Center and also the Center for Mindfulness. And it's been available since 2017. It's grounded in mindfulness-based stress reduction principles, and the Center for Mindfulness itself began with a vision to share mindfulness and compassion with the hospital community. It's donor-funded, so reports and evaluation are really important for the continuation of the center. And it's now become a hub with a ton of programs for the well-being of staff, patients, and caregivers. So I was tasked with creating a evaluation plan and possibly implementing this plan. So the version 4.0, which was supposed to come out in the spring, would include 4 new meditations. So they were Moving Mindfully, Love Letter to the Earth, Coming Home, and also an embodied land acknowledgement meditation, along with the redesigned visual interface. So it was quite an iterative process for me. I had never really come across creating an evaluation plan for something that hadn't already launched. So I kind of stumbled between creating formative to process and landed on a mixed method 2-phase outcome evaluation with a social constructionist paradigm, meaning that we recognize that the participants' experience of mindfulness are shaped by their own social context and personal history. And we got to test out these mindfulness practices on 3 different populations, so youth age 12 to 18, parents and caregivers, and also healthcare professionals. So I just did phase 1, which is focused on engagement groups. So I got to help with creating the surveys and leading the engagement groups with a structured listening session where participants experienced the meditation and then provided feedback. Phase 2 would be post-practicum, and it would include the whole in-app experience. So the theoretical framework that I worked with in my culminating report, and also that I learned about through the training at PHSA, is that settler colonialism as a structure. So settler colonialism is not a historical event. It is a structure, an ongoing structure defined by the systemic erasure of Indigenous knowledge systems and their replacement with settler epistemic orders. Health institutions, including hospitals, are key sites of that structure. When institutions adopt the language of decolonization without material redistribution of authority, resources, or epistemic power, decolonization becomes rhetorical rather than structural. So for evaluation specifically, the epistemic states are pretty high. Western evidence hierarchies, such as randomized control trials at the top, qualitative methods, more supplementary, and community knowledge as anecdotal, are not neutral. They determine whose experiences count as data and what counts as evidence. So colonization continues to shape which knowledges are valued within bureaucratic and academic institutions, creating structural imbalances. So mindfulness as an institution is institutionalized in MSBR and developed through apps like Breather is a westernized secular derivative of Buddhist and other contemplative traditions. The cultural and spiritual origins have largely been stripped away to make it legible within biomedical frameworks. Though Breather does acknowledge this, the tension becomes sharper in an Indigenous context. So relational ways of being, presence, awareness, connection to the land and body were not absent from Indigenous cultures before Breather was created. They were suppressed by the very colonial institutions, including healthcare, that now offers a westernized versions of them back. The land acknowledgement meditation is a sharp example here. So it led to a mid-practicum pivot because we had to consult with Indigenous on what they thought about evaluating this specific meditation, and Indigenous Health had significant concerns. The meditation missed core procedural elements of what land acknowledgement should be and should include. So after 2 consultations, Indigenous Health advised us to pause the evaluation of land and spend more time developing the content collaboratively. And there was a whole host of things that sort of needed to be done actually preemptively. So it was a huge learning process for both myself and my supervisors. And so my team chose to prioritize the relationship over the evaluation deadline. And we didn't end up evaluating it in the end. I wanted to also touch on the mindfulness paradox. One of the directors of the Center for Mindfulness, Dr. Zoom Vo, said something early in the design phase that mindfulness and evaluation don't really mix, which I found to be quite interesting. So mindfulness, by definition, asks practitioners to release attachment to goals and outcomes, and evaluation, by definition, demands goal-oriented outcomes and measurement. So designing an evaluation that honored both of those realities at the same time proved to be quite difficult for me, but in a good way. So my response was to prioritize non-leading, experience-based language. So instead of using "did this meditation reduce your stress?" which is quite a clinical outcome, I asked, "What did you notice? How did you feel during and after this practice?" So a bit more open-ended. So decolonization and its limits. Though I noticed PHSA has robust cultural safety protocols, the Center for Mindfulness team engaged Indigenous Health consultation, and all of this was very meaningful. These were real commitments with institutional investment. However, the evaluation I designed still operated within Western settler colonial evidence frameworks, and the approval processes still centered PHSA's institutional authority, along with the instruments that we used, and me, myself, am a settler researcher. So there is a structural ceiling on how much epistemic redistribution can happen from within a colonial institution, and it means the work requires a clearer-eyed accounting of what is actually happening and what we can do from these structures. I want to close with something I was thinking about and I found online, but not necessarily within the health competency document we were given. So that's structural humility. The tensions I've described, the gap between cultural safety as policy and cultural safety as structure, the paradox of evaluating mindfulness within Western tools, and the limits of institutional decolonization are not all, they're big, heavy problems that cannot be solved in months or even years, but they are structural realities that public health practitioners should keep in mind and must keep navigating. So in the future, I'd like to keep developing my capacity to do meaningful work while holding these tensions in mind. And I also came across I wanted to share some recommendations that came into mind when completing my practicum. So the first one being consulting Indigenous Health at the design, not review. Had we included them in the design process earlier, I think we would have been able to evaluate and have some great feedback for this practice. And then also establishing the Indigenous Engagement Charter for Center for Mindfulness. It removes the structural barrier to include Indigenous participants because we were actually told by Indigenous Health that because there was no charter, it would not be culturally safe to include Indigenous participants in the evaluation, which was another learning curve. And 3, build flexible timelines for culturally sensitive content. yeah, there was a lot of sort of rush and deadlines to get things done by a certain time, especially because my practicum was only the 3 months. And we sort of learned to put that aside and prioritize relational processes. And then the fourth one is diversifying evaluation methods. So two-eyed seeing story-based approaches alongside Likert scales would have been really interesting and also a really effective and efficient way to conduct this evaluation. But there was sort of not enough space to blend the two and to actually learn about and implement these types of evaluation methods. But all of that, I'm really grateful for this practicum, for the colleagues and supervisors who modeled what it looks like to hold these tensions honestly, and for the participants who trusted us with their experience. Thank you to Shar Black and Jeanette Fong, who are my supervisors. And yeah, thank you for listening.